we're really happy that you're with us this morning. I hope you're all safe and healthy and warm. We are going to be talking with Jillian Schauer in just a moment, but I just want to tell you a little bit about this organization. My name is Kim Porter. I'm with the organization called Be a Part of the Conversation. We're in the southeastern portion of the state. Hopefully some of you are joining us from across the state. Been around for almost 11 years now. And most of our programs are for the community. They're intended to raise awareness about substance use and addiction. This project is funded by the Montgomery County Office of Drug and Alcohol, and Mia Coxum is on the call if anyone has any questions for her. But we are really excited to partner with them for this project, which is specifically about cannabis and youth. So the Youth Marijuana Prevention Project is a 5-year grant. This is year 3 of that project. And we've had a lot of really innovative programs connected to this. And this is really intended to help folks just really understand what new policies might look like in Pennsylvania. Is kind of right in the midst of, some legislation looking at adult use, legalization. And we of course have medical marijuana legal here for a few years now. Just a couple of notes about this presentation. We are recording it, but any questions that you submit in the chat or the Q&A will not be part of the recording. They won't be visible, nor will you on the recording as an attendee. And please go ahead and submit questions throughout Dr. Schauer's presentation. The link to the recording will be available later today on a follow-up page. I'm going to share that with you in just a moment. Here it is. Conversation.zone/lead is where you can go, and if you'll give me a little time to process the recording and get it loaded onto our YouTube channel, you'll be able to access it at another time. So Dr. Schauer is going to be speaking for about an hour, and we said that the program would go until 10 a.m., but she has graciously agreed to stay on until 10:30 if there are follow-up questions or conversation that needs to take place. We welcome that. At the end, you will see a survey pop up on your screen. So please take that survey and let us know if this was helpful to you and what other information you'd like to share with us, or questions or comments that you might have. So I want to mention one program that's coming up that is very much relevant to this topic, and that is coming up on February 8th. Our programs are mostly on Zoom right now, so as is this one on February 8th in the evening, called Cannabis, Kids, and Solutions for Anxiety. We know that there are a lot of young people who are using cannabis, whether it's through the medical marijuana program or using it illicitly, but they cite anxiety as a reason, as a very predominant reason that they are using this to quell their anxiety. So we're going to be talking with a clinician about this, as well as we're going to hear from someone who has a history of cannabis use and kind of how he's now on the other side of that. Really hope you'll join us for that. You can find all of our programs on our calendar. Judy's going to be sharing links to these pages on our site with you in the chat, so check that out, please. And again, mentioning the survey. So I'm going to tell you a little bit about Dr. Jillian Schauer. Jillian Schauer, PhD, MPH, is a research scientist in the Addictions, Drug, and Alcohol Institute at the University of Washington. Dr. Schauer is the executive director of the Cannabis Regulators Association, or CANRA, a national non-for-profit organization that convenes cannabis regulators to share lessons learned and to identify best practices to safeguard public health, promote equity, and promote regulatory certainty. For the past decade, Dr. Schauer has been a senior consultant to several federal and state agencies, working on tobacco and cannabis policy, epidemiology, and research translation. Her consulting has included work with the Centers for Disease Control and Prevention, the National Institute on Drug Abuse, and several state government agencies. Dr. Schauer has more than 65 peer-reviewed publications on tobacco and cannabis, and was a senior editor on the 2020 Surgeon General's report on smoking cessation. So thank you so much. And please note that Dr. Schauer is coming to us from Washington State, where it is just after 6 a.m. So especially big thank you for for being here
Yeah,
with us.
thank you so much for having me, Kim and Judy and Nia and team. It's a pleasure to be with you. I'm looking forward to talking with you about this topic. And I know that you are in the throes of things in Pennsylvania right now. So I hope that this presentation can be useful. And please, feel free to ask questions. I'm happy to answer them. So as Kim alluded to, I'm the executive director of the Cannabis Regulators Association, and we're a year old, so I thought I'd share a little bit more about us. Kim covered it pretty well. We're a national nonprofit. We're nonpartisan. We don't take a formal position for or against cannabis legalization. We're really there to pull together government agencies that are involved in regulating cannabis to help them understand what best practices are emerging, to learn from their fellow states, et cetera. Our funding is all public funding from primarily state government agencies, although we do have a couple territories. And you can see from the map who our members are. So Pennsylvania is not a member. So I was particularly interested by the outreach and to chat with you all, given that they're not in our membership and you may not have heard about some of the best practices and sort of the 101 of what's happening with policy. And CANRA is an affiliate of the Council of State Governments, which if many of you are legislators, you are probably very familiar with CSG's programming. So hopefully you're excited about CANRA, but now that you are, I have to share that this presentation is my own. It doesn't represent any official opinions, or position of CANRA, and I don't take any funding from any industry groups or have anything to disclose. So what I thought I would do today is a bit of a, at the risk of oversimplifying it, a Cannabis 101. I'm going to cover a lot of information to really get you entrenched in this topic. I'm going to cover a brief overview of health effects, a brief overview of the national epidemiology and patterns of use, and then I'm really going to dive into cannabis policy and give an overview of public health considerations with a focus on youth, but more broadly as well, and then talk about emerging policy issues. I've now testified in multiple states on the Delta 8 emerging novel cannabinoids issue, and that's a really important one to be aware of for youth and just more broadly for policy. So I will be talking about that as well. I'll talk a bit about public health work to date and then leave you with some conclusions. So this is a map of what cannabis policy in the US looked like in 2015. And I think this might be a slide that I used back in 2015. So you can see it's a bit grainy. Our technology's improved, right? But you can see there is not a lot of legalization that was happening at that time. We had 4 states sort of trialing the adult use, non-medical legalization, and you'll hear me call it adult use or non-medical use. You will not hear me use the term recreational use. I don't think that's an accurate term, first of all, to describe what's happening in policy, but it also can condone, fun or enjoyment. And so many states have moved away from that term. So we had 4 states that had legalized adult use, larger number that had legalized medical use. And you can see all the gray states had nothing that was legal with regard to cannabis. So fast forward to where we are today, and it's a rapidly moving policy train, and now almost every state in the country has at least some form of cannabis or cannabinoids legal. There are only a few states that are sort of holding out, and some of those states have fine print. So Kansas, for example, has legalized CBD, but it can't have any THC. But we've seen a big move now, not just on the West Coast, but also on the East Coast towards adult non-medical legalization of cannabis. And we've seen medical legalization of cannabis come to the southern states. So it's been a very rapidly moving policy train. This is from a paper I recently published with the Journal of National Cancer Institute, just cataloging the year that adult use passed in each of the states that have passed it, whether it was a ballot measure or legislative, if it was a ballot measure, the percent support, and then when their retail marketplace opened. And you'll understand a bit more as I get into the policy. When the retail marketplace opens is really important. Usually, even if it's passed legislatively, adult use legalization passes, and then there's a period of time that could be a year, 2 years, in some rare instances, even more, where it's legal, but there's no legal place to get it. And that can pose additional public health and safety challenges due to illicit market products. On the other hand, a year or 2 years to set up a marketplace might sound like a long time. It's actually very short when you're trying to check the box of setting up an entire market that's not existed in your state before, while protecting consumer safety, focusing on youth prevention, and focusing on promoting equity. So I think it's interesting to monitor sort of the pattern of how long states take to go through that process and the challenges that exist there. We're definitely seeing legalization happen in a different era right now. Initially, and I'm in Washington State, when legalization first happened, the big focus of regulators who were setting up the markets was, how can we make sure that federal agencies are not knocking on the door and shutting down this new marketplace? That was their primary focus, due to the Cole memo. And hopefully most of you are familiar with the Cole memo, but it basically authorized states to move forward with their big experiment of legalization, provided they met a host of things around public health, public safety, drug trafficking, et cetera. There's been a big shift. So the Cole memo has since been rescinded. It was not replaced by anything, but I would reckon to say that most states are legalizing now without fear that the federal government is going to shut them down. That has broadened their ability to focus on some other things like public health and safety. I think the other thing that's happened is, early on in Colorado and Washington, most of the voters who voted to legalize voted thinking that it would immediately resolve the major social justice issues that have existed around cannabis, which are public health issues, and I'll talk more about those a bit. But studies have since shown, and you can see some of the headlines here, studies have since shown that actually equity has not been restored just because cannabis is legal, and that you actually have to legalize purposely, focusing on equity. And I'll talk about what that looks like and what that means. So I think we now see states regulating, legalizing and being able to regulate with more of a focus on social equity and social justice, with more of a focus on public health and safety, which is a very good thing, and focusing on increased parity across cannabis policies. So now we don't just have a couple states doing adult use and some holdout states doing medical. We have hemp that's legal as well, and states are having to reckon with, how do all of those legalized systems work together, so that you don't leave gaps on any of the important things, particularly with regard to public health and safety. So it's a fast-moving policy train. There have been a lot of changes. What does the science suggest? Is the science, in the same place as policy? I'm going to start by talking about the therapeutic effects of cannabis and cannabinoids, because I think this is something that makes cannabis very different from a substance like, say, for example, tobacco. There is scientific evidence for therapeutic effects. Most of that evidence is around therapeutic effects from cannabinoids, which are the individual chemicals in the cannabis plant. And FDA has approved certain cannabinoid drugs that you can see at the bottom. In Europe, they have even a broader range of cannabinoid drugs. So it's really important to keep that in mind when we look at the science around medical use. It's not all just from whole plant. A lot of it is from drug development. And there may be some differences there. So far, the most promising evidence is for relief from chronic pain. And I'm happy to take questions on the cannabis opioid sort of relationship. I hadn't planned to cover that here, but there's certainly a lot I can say about that if that's an area of interest. For relief from nausea, for patient-reported symptoms from multiple sclerosis, for rare seizure disorders like Dravet's, and then there's some evidence for sleep. If you look at this list and think about, I don't know all the details in Pennsylvania, but if I think about most states that have medical use, they've authorized much broader use. Some of that broader use has been due to sort of political pressures or advocacy. Some of that broader use is because there is promising science emerging that's not yet in a robust form, and some states have opted to act sooner than the aggregated science might suggest on that. So let's talk about some of the health risks now. We're still in a pretty nascent stage with science, and I'll talk a bit more about that when I get to the chronic effects. But when we talk about acute effects, so these are effects that can happen to you even if you're not a regular cannabis user. If you use it, once or twice, these are things that could occur. It can impair memory, learning, and attention. in the short term, and I'll talk about what we know about the long term. It can impair motor coordination and reaction time. It has been associated with a higher risk of motor vehicle crash, although data make it very hard to assess the true magnitude of that. What we do know is the risk is there, and we know the risk is definitely magnified when cannabis is combined with alcohol. That is not a combination that you want to see on the roads. We know in high doses, cannabis use can lead to acute psychosis and paranoia. And this is really kind of the overdose effect of cannabis. You don't see cannabis causing respiratory depression like we see for opioids. That's primarily because the receptors that the chemicals in cannabis bind to are not overly present in the lungs. But in naive users, especially if they consume too much, it can cause this acute psychosis that in rare instances has led to death. And early on in Colorado, there were some pretty prominent cases. An individual consumed too many edibles and jumped off a building. You know, there was intimate partner violence caused by this. So it's definitely something to pay attention to and to do education about. And then cannabis use can also alter judgment and increase a host of other risky behaviors, everything from sexual behaviors to injury-based behaviors, which have importance for public health. I recently added to this slide emerging data on cardiovascular effects from smoking cannabis. There's some really fantastic studies out of the University of California, San Francisco, folks who've done a lot of work about the impacts of secondhand tobacco smoke and, direct tobacco smoke in people who smoke tobacco have started to do that same research in cannabis. And what they're finding is that, in fact, cannabis has many of the same effects. It contains many of the same constituents in the smoke, and those constituents have the same kind of effects in the body. And in some cases, they're a bit more exacerbated. So the risk of heart attack is something to pay attention to in people that are smoking cannabis or are around individuals who are smoking cannabis. So the longer term effects, the science gets a bit more dicey. And I think we're living in an era where you can find a study to support whatever you want to say about the health effects of cannabis. That's really important to understand. And to be good stewards of the science, I strongly suggest going to review articles. And there are a handful, now some a bit dated. I hope we get something more updated, but the National Academies of Sciences put out a really rigorous report in 2017 on the health effects of cannabis and cannabinoids, included details on both benefits and potential harms or risks. The state of Colorado is statutorily mandated every 2 years to produce a report on the health effects. Their reports are searchable on the Colorado Department of Public Health and Environment. They use a rigorous scientific approach to doing this, and their reports are keeping us updated. So they're currently in a report year. So in December, they'll be releasing another. I think they've already released 4. And then the WHO has a now quite dated report from 2016 that's more narrative. So again, go to the reviews. We're living in an era where you can, pretty much find a study to say whatever you want to say about cannabis. But what do we know in aggregate? What we know is mostly by correlation or association. So it's not causal. And that's a really important caveat. I think we probably know less about the health effects of cannabis right now than we did about tobacco in 1964 when the first Surgeon General's report on smoking and lung cancer came out. That's because that Surgeon General's report on smoking and lung cancer created a causal link. We knew that smoking caused lung cancer. What I'm going to cover with you now is mostly that we know that when something happens, this is present, but we don't know that it's a causal link. So we know that using cannabis is associated with cognitive development impairments and related outcomes. And I'll talk much more about those in youth, but we know that cannabis impacts the brain and at least in the short term can impact those learning domains. We know that using cannabis is a cause of cannabis use disorder. That's one of the causal links that we know. It seems obvious, but there was a long time where people said you cannot get addicted to cannabis, and that's just not true. In fact, about 1 in 10 to 2 in 10 consumers do have some cannabis use dependence or disorder. I'm often asked about the gateway effect. Does using cannabis, particularly in youth, lead them to go on and use a lot of other hard drugs? We do not have science to support that. What we do have science to support is that if you use cannabis and you use other substances, it will be harder to quit those other substances, whether it's tobacco or cocaine or pills, something else. Cannabis seems to prime the reward center and can make quitting those other substances more difficult. We know that cannabis is linked to a number of respiratory effects, with bronchitis being the predominant one. We know that cannabis is linked with pregnancy outcomes and primarily lower birth weight. That's where we have the most science around, although there are certainly studies that suggest other neonatal development concerns. I wouldn't say they're enough for us to say that we have a body of research that can suggest that. And then where we actually do have substantial research, which is unusual because it can be hard research to conduct, is on mental health outcomes. So we know that cannabis is a risk factor for the development of schizophrenia, and in particular in people that may already be primed to develop schizophrenia. We know that cannabis can lead to earlier and more severe diagnoses. We also know that cannabis can exacerbate a range of effects in people who have other mental health outcomes. It has a small association with depression, with certain types of anxiety, can exacerbate certain symptoms of bipolar disorder, et cetera. So this is a really important one to pay attention to for youth. And it may be that people who initiate cannabis earlier and have heavier use patterns are more prone to these. The Surgeon General from the last administration released an advisory on cannabis and youth and pregnancy in particular. And there's an underlying reason why he released that advisory, and that's that cannabis does interact with the brain. The brain has a number of those receptors that the cannabis molecules can bind to, CB1 and CB2 receptors. So the prefrontal cortex in particular has a bunch of these receptors, and prefrontal cortex is one of the last parts of the brain to develop in youth. It's responsible for decision-making, for impulse control, for attention, planning, social responsiveness, motivation, reward. And because it's one of the last to develop, it's particularly vulnerable to substance use and particularly to use of THC. However, the science is not exactly clear on what the outcomes of that are. So this is a bit of a busy slide, but I wanted to take it as an example to paint why the science isn't as clear as we might like it to be. On the one hand, when we think about cannabis and the brain, and we do know that cannabis affects the brain, we see multiple reviews that cannabis can affect the areas I just talked about, that those effects have been linked to earlier age of use and frequency of use, that those effects can be longer term, 3 years or more, and that those effects can be associated with a range of outcomes: school absence, dropout. There's some that show, it has an impact on educational attainment and your success in the workforce. But on the other hand, there are also studies that show that these are inconsistent and unclear results, particularly the ones related to school performance and later employment. That effects may actually be due to residual withdrawal symptoms and may not be due to cannabis itself, that effects may not persist after you truly stop using cannabis, that effects may differ by subpopulation or individual characteristics, and that effects may be impacted by other substance use, by pre-existing or genetic differences. And this is such a sort of quandary in science that the National Institutes on Health has undertaken an adolescent brain and cognitive study to better understand sort of the causal relationship here with some of these long-term effects. So I think it's very safe to say cannabis does impact the brain, and certainly in the short term that can have really important consequences, but we just don't understand enough about the long term and all the factors at play at present. So why don't we know more? Well, hopefully all of you are aware of just how hard it is to study cannabis in this country. It's a Schedule I substance. Researchers have to jump through a lot of hoops to actually study it. And that has blunted, I think, our ability to have more research in this space. I think another reason is that cannabis does overlap with other substance use that can cause similar outcomes, and that can make it really challenging in studies to delineate what is due to cannabis and what is due to another substance. And then finally, cannabis is a heterogeneous product. We are not doing a good job studying the range of products that are out there. Those may change use patterns and outcomes. And our data systems and monitoring systems have not adequately measured how much cannabis people are using, what form they're using it in, et cetera. And that will all have implications for what we know about the effects. So who's using cannabis? These are national data from the National Survey on Drug Use and Health, and the patterns have been fairly consistent over the last decade. You can see the orange line are young adults, age 18 to 25. They have had the highest prevalence of past month use, and their use has been increasing as we've seen policies change. This is really important because the brain is still developing until the age of 25. And so I think often we focus a lot on adolescents, and my personal opinion is we need to focus much more on young adults. You can see the gray line are adults 26 and older. They've generally had a fairly low prevalence of use, but that use has really been increasing with legalization policies. And then the blue line are youth age 12 to 17. That has been a pretty flatline trend. And that flatline trend is repeated no matter what state you look at, pretty much. It's repeated in Washington, where we've legalized for a decade now. It's repeated in Colorado. It's repeated in Alaska. If you stratify data, you can see some differences. For example, Alaska's seen an increase in high school girls using cannabis. But overall, in adolescence, it's been a pretty flatline trend. So people often say, well, that's past month use. Youth are using more. So let's look at those data. These are daily or near daily marijuana use among marijuana consumers. You can see here, again, the highest prevalence has tended to be young adults. Nearly 20% of young adults are using daily or near daily, which is a lot. And you can see that older adults have caught up with young adults as legalization has continued. So daily and near daily is important to pay attention to, because that's often where we'll see the health effects I just outlined sort of consolidated. That is a risk factor for many of those health effects. But we see this flatline trend among youth now. So that might seem like good news, but before we conclude that cannabis legalization is not having an impact on youth, I'd like to point out some data from Monitoring the Future, which is a study that is longitudinal. So it's a study that happens year over year in high schoolers. And what we've seen in Monitoring the Future data is that this is pretty much the healthiest generation of youth in terms of substance use that we've seen in a long time. COVID may change that. It's very important to monitor that. But pre-COVID, we were seeing declines in alcohol use, we were seeing declines in binge drinking, in cigarette use, even in use of illicit drugs. There are only two areas where we weren't seeing those declines. One was with regard to vaping, which I would argue is not a substance. It's a device that can be used to consume a lot of substances. And the other was with regard to marijuana, where again, we see this flatline trend. So it may be that legalization policies are creating a flatline trend that would otherwise be declining. And that's something that's really important to monitor and continue to study. And just with regard to the vaping, and I think, we've seen in COVID that this has certainly leveled off, but there's been a huge increase both in vaping nicotine and in vaping cannabis. And the trends, while cannabis vaping has tended to still be lower, have mirrored each other. And I think one of the challenges is that you really can't tell what kids are vaping these days. The vaping devices look very similar, they overlap. You can have cannabis that is vaped that doesn't have a scent. So I think this is an important area to continue to focus on for youth and for prevention. So now I'm going to shift to the policy variables that I think matter the most for public health and safety. And I would sort of categorize these in three big areas. I think there are three outcomes that are really important when we think about policy. There's certainly more, but the three I would put at the top of the list are youth prevention, consumer safety, and equity and racial justice. And so I'll allude to those as I go through the policy variables. I'm going to talk about the regulatory structure that we're seeing and make some comments on that, price and taxes, equity programs, legal amounts and home grow, the availability of products, serving size and concentration, the use of additives and flavors, packaging and labeling, advertising, point of sale and retail requirements, and public consumption. So I think the first question for public health is, how are you regulating? What regulatory scheme are you choosing? And there are a range of schemes that could be chosen, right? In pre-legalization, we were really sort of over on the far left hand of this diagram, prohibiting cannabis, with sanctions. We have moved in every state that's legalized adult use clear to the other hand of the spectrum, to the right-hand side, with a standard commercial model. That standard commercial model can make protection of public health and safety very difficult because entities have a profit motive to increase use, to increase users. There are a range of options, some of which have been tried in Canadian provinces in the middle that probably have more compatibility with public health outcomes. The government operates the supply chain, so government runs stores, a public authority, which is a near monopoly, nonprofit organizations, for-benefit companies. There are a range of approaches that could be considered by states, but aren't. And I think, if I'm being frank, I think it's unlikely that any of these regulatory schemes will be taken up by any US state, because we've already developed a commercial industry that is, actively advocating for legalization following this standard commercial model. But I think it's important to mention the range of regulatory schemes just to sort of root you all in what could be and what is in some provinces in Canada. So what are the taxes and where do they go? This is important to public health for a lot of reasons. We know that the price point can both fuel the illicit market, but it can also make products so cheap that they can easily be diverted. So there's a real sweet spot. We see a range of taxes in states that have legalized from, around 6% in your neighbor of New Jersey, all the way to 37% in my home state of Washington. Most states sort of land on a 10 to 15% excise tax. So that's a tax that's charged at the point of sale that the individual purchasing the product clearly sees, I'm paying this extra tax because I'm buying cannabis. Alaska is the only state that doesn't have a user-based excise tax. They don't have a tax at the point of sale. Their taxes are all on wholesale. An emerging trend that I think may have some impact on the types of products that youth can get a hold of is one that we see in Illinois and New York, and they are taxing based on THC. Illinois has a tiered system where higher THC products have a higher tax, which again should make them less available to youth. They're more expensive, and youth don't tend to gravitate towards the more expensive products. And New York is going to be charging a per milligram tax on THC. So it'll be interesting to see sort of how that works out. But again, in theory, that should make high THC products more expensive. Taxes fund a range of things. You can see here from state to state: schools, public health, although very small amounts going to public health, I should say, mental health and substance abuse, public safety, traffic safety, research, local government, basic health and wellness, roads, recidivism, criminal justice, community reinvestment, et cetera. Obviously, my personal opinion is that taxes should fund public health, prevention, mental health, substance abuse work. If you're legalizing a substance, you ought to fund some of the work to prevent externalities from that substance. And we've not tended to see that be one of the heavily funded areas from taxes. The area that's growing that I think is really important is that funds are being increasingly used to promote social and economic equity. So you may be following some of the discussions on, in the Eastern Corridor about this, and the media tends to pick up most on the discussions around equity in the market. Are you creating a licensing structure that allows communities that have been disproportionately impacted by past criminalization of cannabis to get into the market? That tends to be where the media likes to focus. And that's important for a lot of reasons, but I think there are two other areas that are really important for public health. One is expungement and resentencing. We know that anyone who's had a criminal record around cannabis, people who've lost family members to the criminal justice system because of cannabis, that forever changes all of your health and wellness outcomes. I am so sorry. I'm going to have to let my cat out, or you're going to hear a cat. Give me 1 minute.
No problem.
I'm so sorry about that. So expungement and resentencing is really important. You can't legalize a substance and leave people in prison for that substance. And we're learning a lot more about how to do this well, how to make it automatic, how to make it so that people don't have to do a lot of paperwork to get expungement for cannabis-related criminal justice encounters. The piece I'm probably most excited about, though, for public health and safety is this community reinvestment piece. We know that when communities have lost huge numbers of people to the criminal justice system because of cannabis, which has happened in a number of communities, it forever changes their health trajectory, even if you are not the person that had the criminal justice encounter. If it was a family member for you, if you're a child and a parent, had a criminal justice encounter related to cannabis, you will have a different health health trajectory. And that has been something that I've watched public health for 2 decades struggle with how to address. These are deep issues, not just racism, but issues that are foundational, that are typically not funded in public health. And what's exciting is states are now starting to put huge amounts of money to reinvest in these disproportionately impacted communities, to work on some of these foundational issues to try to create more equity. These are things like job placement, mental health treatment, substance use treatment, system navigation services, legal services, linkage to medical care, housing. Again, really those foundational things. And we see California and Illinois have been out front. California is putting $50 million a year into these issues. Illinois is not far behind. We will see Virginia, New Jersey, New York will all be putting millions of dollars, in the case of New York, hundreds of millions of dollars into community reinvestment. That's not just tied to cannabis, that's tied to these larger foundational risk factors for health and health equity. So I think this is a really important area to watch, and something that's an important outcome from some of the policies that we're seeing. So what's legal? The amount of cannabis that is legal in most states is 1 ounce. It's really important that policies also have an equivalence for concentrates. So most states have used a study out of Colorado, and they have a 1 ounce plant legalization limit, or 7 to 8 grams of concentrate. I show this visual because that's quite a lot of cannabis, just so you can visualize how much that is. And we still see some states that have even more than that. There are a couple states that have a 2 ounce possession limit. I believe New York is 3, and then there are a couple states that have a higher home possession limit up to 10 ounces. The types of products that are legal, we really, on the adult use side, have not seen many restrictions here. You can find everything from, plants to edibles to beverages to concentrates and vape cartridges to pills and tinctures. The only area we've really seen states undertake policy in is around edibles, and there are a handful of states that have required shelf-stable edibles, and that's primarily an artifact of the Schedule I designation of cannabis, where a lot of food inspectors and public health programs that get federal funding don't want to have to inspect cannabis products. And so by making them shelf-stable, you remove some of the food inspection aspect. But I think we are seeing, and I'll show on the next page, some trends that suggest that we may need to think a bit more about the products that are out there and how they may appeal, in particular to children. There are a few states that have a pre-approval process where all products, or a sector of products, have to go through pre-approval with the regulator to decide if they may be appealing to children. So Nevada reviews every single menu item to make sure that it's compliant. Washington State reviews edibles. Their review of edibles has, over the years, faced discussions about, like, does a hot chocolate appeal to kids? What shape of a gummy might appeal to a child? Those are really hard decisions to make and quite subjective, but I think those discussions are important. And then home grow is legal in almost every state. There are a couple states, including my state of Washington, that allow home grow only for medical use, not for adult use. Home grow is an important variable because products grown at home can be more easily diverted to the illicit market, to youth, and products grown at home are not tested for consumer safety. So if they are diverted, you may have contaminants. They're not required to go through the same testing. Home grow in medical programs has been important because some people do have strains that they grow for a certain ailment or health issue. But on the adult use side, at least a couple of states have decided that they don't need home grow for adult use. They're providing a whole marketplace. What's allowed to be in the products? This really came into focus during the vaping lung injury outbreak, and I'll talk about some of the policy levers that were enacted in the wake of EVALI. But states have really focused increasingly on flavors and terpenes. So it's not like nicotine products where people are just dumping in random flavors. The cannabis plant does have a flavor profile that's different than a lot of other substances. The part of the plant responsible for flavor is called a terpene. And terpenes come in a variety of flavors that can be extracted and added back in. And so I think what happened during EVALI is people started to scrutinize a bit more what is being extracted, what's being added back in. Is what's being added back in from the cannabis plant, or is it being made synthetically? Is it safe for aerosolization? Are there flavor profiles that are being marketed in ways that would appeal to kids, et cetera? Excipients and diluents also came under focus during EVALI because, of course, vitamin E acetate was being used to dilute vape cartridges, and that was implicated in the vaping lung injury outbreak of 2019. But it turns out, most vaping cartridges for cannabis are using a range of dilutants to make the cannabis more viscous. Cannabis, when you extract it, is not like nicotine. Nicotine is water soluble. Cannabis is fat soluble. So the extract can look like a resin and often does need to be mixed with some sort of carrier oil. And I think states are taking a lot more care in their rules to look at what are these carrier oils that are being used and are they safe for aerosolization? And if they're not, where do we draw the lines? There's also, been consistent policy on other additives like nicotine and alcohol, with every state preventing those from being added to cannabis products, which is very important for public health. You cannot make a product that's nicotine in cannabis or alcohol in cannabis. What I think is interesting, and these are two pictures I took in the California marketplace just last month, is we're starting to see alcohol brands moving into the cannabis space and producing cannabis products. So you can see this Lagunitas beverage, you can see this Pabst Blue Ribbon beverage. These products do not contain alcohol, but they are very clearly alcohol brands making cannabis products. And I think that's a trend area to pay attention to, because it may put the two together in people's minds. And again, we know that the combination of alcohol and cannabis can be particularly concerning for impaired driving. The other things that have come from EVALI, wider disclosure of ingredients being used. Companies, were claiming trade secrets and, for example, including these added terpenes without telling regulators what everything, included in the terpene blend was. And states have gotten much better in their rulemaking at requiring ingredient disclosure, even when trade secrets are being claimed. And then testing, obviously, is particularly important, not just in the wake of EVALI, but more broadly, testing for a variety of contaminants. I could give a whole separate presentation on testing, so if you have questions about it, please ask. But I think the protecting consumer safety really came into focus after EVALI. As I said, there's been more regulatory authority taken over these additives to prevent future safety issues. There have been bans or the authority given to regulatory agencies to ban potentially harmful additives. Previously, regulatory agencies in states didn't necessarily have the authority to say, we've identified this potential harmful ingredient and we need to ban it now. Focus on using pharmaceutical grade or FDA approved additives for that particular intended method of use is something that states are moving to as well. More regulatory authority over vaping devices themselves. So we've seen, especially a number of medical states, put rules in place around a requirement of temperature controls so that the device doesn't overheat. And when you aerosolize something at a very high temperature, it can create different byproducts that are even more harmful. Making heating elements out of inert materials. We've seen improved approaches to facilitate rapid recall processes, but there are still challenges. We do not have good safety profiles on most of these additives. There's no state that's been able to, nor as a scientist would I be able to say, this is the safe excipient to use, or this is the safe additive to use. They all have potential issues, and we just don't know. They've not been well studied. There's emerging policy on cannabis concentrates that gives me a bit of concern personally. We've seen a lot of states legislatively have moves to cap the amount of THC in concentrates, to say you can't make products that have more than 60% THC or 30% THC. And my concern there on the wake of EVALI is what that's basically forcing is that 30%, 40%, 60% of the product then has to be all these garbage additives with unknown safety profiles. So I think we need to be very careful in policy that we solve the problems that we have without creating new unintended consequences. And then the separate marketplace for hemp has been a big challenge because hemp is being regulated in a very different way than cannabis in almost every state. And these additives are being used in hemp vaping cartridges as well. And there's not the same oversight. So how are products packaged and labeled? I think there's increased focus on the potential for uniform packaging. And many of the medical states have uniform or plain packaging, but we're starting to see some of the adult use states, at least in their statute, say that the regulators could pursue uniform or plain packaging if desired. Our neighbors to the north in Canada have uniform packaging. You can see an example of that. What that means is every package looks the same and it's plain in its look. So you can see on the Canadian package, there's a little area for the branded element, but otherwise it looks pretty plain. That can be important because, on the other hand, most of our adult use states in the US have provisions in statute that say products cannot appeal to kids. And they may even delineate that a little bit. Can't contain bright colors, can't use certain fonts, can't use cartoons, but that is very subjective to enforce. And so you can see at the bottom right of the screen, these are some products that are, on the market in states that have those policies in place. And these products include, use of sort of spokespeople branding and, use of bubbly letters and use of bright colors. And so I think it's been very hard for states to figure out how to subjectively enforce the provision that packaging shouldn't appeal to kids. And an easier enforcement approach and a better approach for public health would be to use plain and uniform packaging. Right away, this meets the packaging that we outlined, et cetera. I think there are also some hybrid approaches that could be used. I think you could say in the store, which is adult only, you can advertise the product however you want. When it leaves the store, it has to be plain packaged so that what gets home, what gets out in the community is not particularly appealing to kids in terms of the packaging. We've not seen any state do that yet, but I think that would be an option. The universal symbol has been a really important development in policy over the last decade. Early out the gate, that wasn't on products. That's a symbol to denote, hey, this product contains cannabis. Colorado didn't use that right off the bat, and they ended up having a number of inadvertent consumptions by adults. People who were cleaning a room after somebody, had left a hotel and there was a packaged brownie and, they took it home and they didn't know that it contained cannabis. So the purpose of these symbols is not to market cannabis at all. It's to alert people this product is different and contains cannabis. You need to be aware of that. You need to take care. You can see there's a range of different universal symbols that states have come up with. The East Coast is sort of consolidating around one. We've got Connecticut, Massachusetts, and Maine all using this one right here that you can see kind of in the middle. Montana's opted to use one that is developed by a standards making organization that's focused on trying to unify the universal symbol. But so far, most states have their own universal symbol. Inclusion of a poison center phone number and or a drug information website is also something we're starting to see states move to. I think that's particularly important because you want to give people a resource on the product. And then labeling for total THC versus Delta-9 THC is another important trend we're seeing, and I'll talk about that a bit more with hemp. But there's still challenges. We still have, very ineffective warning labels. These are a couple examples down here that are very hard to read. They're hard for consumers to read as well. They're probably not being read. Warnings are probably not being digested by consumers. Again, I think Canada's doing it a bit better. They have, half of the package is this big yellow box, and they have rotating warnings. So every product has a different warning on it. They don't all have 15 warnings. They try to, hit consumers with one that hopefully they'll read and digest. So I think we have a lot of potential improvements to make there, and we're just generally not reaching consumers with effective information. These are data from the International Cannabis Policy study, which is conducted by Dave Hammond out of the University of Waterloo. And he's been surveying cannabis consumers in US states and Canadian provinces since 2018. He has a really unique survey. He asks more than 100 questions just about cannabis, uses sort of a market panel to get the sample. And he's asked some interesting questions of people about what they know about THC or CBD and the products they last used. So the American flag, those are medical states. The flag with the pot leaf, those are adult use states. And the Canadian flag, obviously, are Canadian provinces. So he asked in 2020, do you know the amount or the number of THC or CBD in the dried plant that you used last? And you can see that even in adult use states, less than 30% of regular cannabis consumers could report how much THC or CBD was in the product they last used. When asked to report what that number was, the average was 33% THC, which does not exist in most plants that I've seen. So these data suggest to me that consumers really don't even know what they're consuming. And that is a challenge when we're trying to protect consumer safety. Another variable that I think is important to focus on for youth and for social norms is advertising. There's been an increased focus in states on advertising restrictions to prevent youth exposure. So previously, most states legalizing adult use cannabis were borrowing a provision from the alcohol industry that said 71.6% or more of your viewership of an ad has to be reasonably expected to be adult. When stated differently, that's like saying almost 30% of your viewership can be underage. And I think when we state it that way, it's extremely concerning. So we've seen a number of recent states to legalize change this number. Connecticut has set that threshold at 90%. So they are really creating adult only or trying to create adult only advertising in Connecticut. I think New Jersey is 85%. Virginia, I think, is also 85%. So that's a good thing. That may eliminate some of the mainstream advertising mechanisms that really are pervasive and reaching youth. There are some limitations or bans on advertising in certain outlets, but there's been concern about First Amendment rights and infringing on that. And so I don't think we've seen states really test the waters there. We've also seen states move to have some restrictions on ad content, can't contain a marijuana leaf, can't contain celebrities, can't contain cartoons, et cetera. And we've seen states move to have some warnings that are required on ads as well. I think the big challenge for states is social media advertising and third-party advertising. So all of these pictures on the kind of far left of the picture bar that I have, these are all from Instagram and online, social media. These are from websites that could be accessed by youth very easily, that there's no age restriction. And that has been a particularly challenging area for states to try to regulate. The other area that's been hard for states to regulate are these third-party advertisers, Weed Maps, Leafly, et cetera. They've taken out billboards all over Washington state that say things like, when cannabis is legal, opioid deaths go down, stuff like that, the state has no ability to do anything about because they're not licensees. So I think we're seeing states try to test the waters there. Connecticut's advertising provisions in statute will apply to anybody, whether they're a licensee or not. So it'll be interesting to see how that affects things. What requirements exist for retail stores? This is another question I get that I think is important for youth. All states have some zoning setbacks, and these zoning setbacks are often able to be changed or set locally as well. Usually it's, anywhere from 500 to 1,500 feet from schools or child-based locations, et cetera. These zoning setbacks can make it so, particularly in urban areas, there are only certain areas of the city where cannabis stores can locate. So I think it's important that they are coupled with density caps, because otherwise you can end up with certain areas of a city that are often low income that meet the zoning setback requirements, and you just get a row of pot shops. And that's not great for communities either. So the density caps can put some limitations on that and try to spread things around so you don't have sort of a cannabis row. Most states have limits on what's allowed to be sold in the store that make it so it's typically cannabis only. Some states allow paraphernalia as well, but again, thinking about tobacco control, it would be a dream to have tobacco only stores, to not have tobacco in every, grocery store, gas station, et cetera. That's what we currently have for cannabis right now. And I think it's important to protect that, to keep these as adult only establishments that can't sell a bunch of other things. And the compliance is quite high. There's not a lot of youth access that happens because these are adult-only retail stores with required ID checks at purchase. I think in Washington state at last check, compliance was like 96%. So very high. Youth are still getting these products, but they're getting them through other diversion channels. They're not going into the store and buying them themselves. The people who work in the stores, most states call them bud tenders. I think there's a real opportunity in public health and prevention to do more training of them. They give a lot of information, and we've generally in public health and regulation not done a lot to give them any training around that. Where are people allowed to consume the products? This is particularly important given what I shared about what we're seeing on the health effects of secondhand and cannabis smoke. And this stands to potentially roll back the policies that have been created around tobacco and secondhand smoke and clean indoor air. So even if we didn't know anything about the science of secondhand cannabis smoke, just the idea that this might re-normalize smoking, I think has some public health concerns for me. So public and social consumption is prohibited in a few states. A few states, California and Illinois, have sort of kicked the issue to the locals to say, if you want to allow it locally, we'll create an exemption in our Clean Indoor Air Act, but you've got to vote on it locally. And then we now have 4 states that have statewide licensing with local approval needed, but it's allowed at a statewide level. And they're licensing for it. Alaska allows it in retail stores. Colorado allows it in a variety of establishments, including in mobile buses and vehicles that have a license for it. Michigan allows it pretty broadly as well. And Nevada's in the process of creating rules around it. And then Massachusetts has allowed it, but it's currently in violation of state law. So you won't see public and on-site consumption locations in Massachusetts. I think there are a lot of reasons that regulators have pressure to do this. One is around equity. If it's legalized and people live in rented housing or federal housing, it's really not legal for them without criminal, engagement or action. So that's a real problem that needs to be addressed. The other challenge is for tourists. States tend to get tourists that come and want to consume cannabis, and hotels don't want it. And so where do you create a space for that? But I think the dialogue could broaden from what we've seen and talk more about how to use outdoor spaces and not compromise the indoor spaces that we have. Emerging areas of focus, and kind of wrapping this up, I just want to talk very briefly about hemp-derived cannabinoids. So hopefully most of you have heard of delta-8 THC. There are a bunch of others coming out of hemp: HHC, THCO acetate, delta-10. These are compounds that are being chemically converted from hemp derivatives. So people are taking CBD from hemp, and they are using a chemical process. They're using a heat, they're using a solvent, they're using an acid, and they're making these other cannabinoids. There are some pretty important public health and consumer safety issues here. One is that these cannabinoids, because they come from hemp, are widely available in retail outlets like gas stations, grocery stores, online. They're widely available to youth to purchase. You can go online, and I've tried it. You can put something in your cart and never have to do much more than check that you're 21. They are not subjected to the same packaging and labeling requirements. So they don't even have to say that they're impairing or how impairing they might be. They're not subjected to the same testing requirements. Some of these new cannabinoid products like HHC and THCO acetate, we literally have no data on human consumption of these and what they do. There can be dangerous manufacturing. There can be unknown byproducts, literally compounds in these derivatives that are identified and have never been seen before. We have absolutely no safety profile on them. And then importantly, they may undermine the adult use markets that are being set up and create this marketplace that's much more accessible to youth and has a much lower price point. So I think a lot of reasons to monitor this and be concerned. The CDC released a health advisory notice about this a couple months ago. They found some 660 cases of adverse events reported to poison centers in just the first 7 months of 2021. 18% of those cases resulted in hospitalization. Almost 40% of those cases occurred in youth that were under the age of 18. And just to wrap this topic up, many states are trying to take legislative action to bring these types of impairing hemp derivatives under the cannabis regulator to say, hey, these are the same things that we're trying to sell in our adult use and medical markets. They ought to be regulated the same way. And a number of states have had success in doing that. So second to last slide, what is public health doing? I've talked about a lot of, the importance of policy, a lot of maybe concerning areas. Public health, I think, has a really important function in collecting data, monitoring what's happening in use patterns and products that are being used. That work needs to be funded, and ideally needs to be funded out of legalization policies. Public health also needs to be engaged in public education, and that work needs to be funded. States that have done this have tended to educate about the law. It turns out that when you legalize cannabis, people think that means all sorts of different things, and it's really important to tell them this is what it means. It's still illegal for youth. You can't give it to youth, et cetera. Drive High, Get a DUI campaigns are also important. Campaigns for kids and trusted adults and parents in their lives are particularly important, and a number of states have done formative work to develop those. Reaching pregnant and breastfeeding individuals, also important because of the brain development. And then states that have been at this for a while, like Colorado, have reached a point where they're now also educating adult consumers for responsible use. Public health is also building coalitions, educating on this topic, contributing to research, educating policymakers, so lots of roles. So I think in conclusion, we're still very early in this experiment. There are a range of health concerns for youth, for the developing brain that I covered, and we still don't know everything that could come from this. The precautionary principle is warranted. With that said, youth use has been stable amidst changing policy. There are a number of policies that are important to focus on to protect youth, to protect consumers. Hemp policies are creating challenges to doing that because it's a whole separate regulatory approach. Public education and data monitoring are really important for youth prevention, and I think also for understanding consumers. And engagement from a variety of stakeholders is really important for good policy. And I often see, only the industry coming to the table to testify at hearings. And so I think it's important for public health, prevention, for folks working in the community to come testify on what matters to them so that you can get policies that reflect that in Pennsylvania. I think that does it. And I'm a minute over. I hope we didn't lose people in the last minute. Happy to stay and take questions.
Oh, thank you so much, Dr. Schauer. That was absolutely fascinating. I'm so grateful that we're recording this because I know this will be really beneficial to a lot of folks. And some folks did mention they had to jump off, but they're looking forward to the recording. We do have a couple of questions. One of our state reps sent me a link to an interesting article that was talking about, he'd like to know more about your thoughts about this gateway phenomenon. And he said, I'm very interested in this study referenced in this article, in particular, the data showing that one of the best predictors of heroin use was early use of marijuana or alcohol. Could you speak to that data in terms of that gateway drug discussion and how that should impact our policy decision on adult use?
Yeah, so I think you can probably, that's not my phone, just FYI. You can probably find a range of studies that are similar to that, and I've seen those as well. I think the challenge, again, is it's a correlational study. It doesn't, a predictor means that something existed and then something else happened down the line, but we don't know that cannabis use is causing that heroin use. And that's exactly what I was alluding to as challenging when we think about youth. There are probably a bunch of underlying factors that predispose youth to substance use in general, risk and protective factors. And so the science at this point shows that those risk and protective factors may play a stronger role than cannabis, for example, than leading to somebody using heroin. It's more that they may have an environment, a family environment, mental health issues, et cetera, that are predisposing them, genetic issues that are predisposing them to use substances. And so we do tend to see polysubstance use in youth. It's just too hard, given the science we currently have, to say that heroin use is because you used cannabis. It's, a bit maybe easier to say you're predisposed to substance use and you're using a variety of substances and you may have started with cannabis. But I strongly recommend the National Academy of Sciences report, which has some good language to discuss the science and what we know on this. And I hope it evolves. I hope we down the road, because of the study that NIH is conducting, the alcohol and brain study, I hope that we have a better understanding of what actually causes it and if cannabis plays a role. But I haven't seen data to suggest to me that gateway phenomenon is supported by the science.
Wonderful, thank you. And certainly know that even if it is correlation, it's still a risk factor and,
yes,
and important to be wary of.
Yep.
You talked about zoning restrictions in some states. Is there a gold standard? Is there a right way to do it in your view?
I think the gold standard in my view would be, again, that zoning is coupled with density so that you don't end up with these areas of a city that often are low income that just have a ton of cannabis stores. I think that's not good for communities either. Generally, we see this sort of 500 to 1,000 feet. I think we obviously want to avoid the pot shop across from the high school and, you know, the pot shop across from the daycare. And so I do think it's important to think about what are those places where youth convene and to put those on your list and to create zoning where you don't have that. I also think it's important that we have zoning for advertising. You also don't want the billboard right across from the high school or the billboard right across from the, you know, youth development center or whatever it may be. But, you know, I think every community has to look at their own reality and sort of think through what's the right distance and what are the right locations for your community. So I do think the local control in zoning can be valuable to have. And certainly setting a floor in statute, not a ceiling, is important, I think. So maybe your statute says 500, but localities can increase it. I think that's important to give that, empower locals with that control.
Thank you. And I can tell you that here in Pennsylvania, we do have a lot of electronic billboards with medical marijuana dispensaries. They're ubiquitous. And we are starting to see some shops pop up with CBD and kratom and saying no medical card needed, real big and bold in their advertising. So, we're definitely in those waters. What is the research showing regarding the outcomes of using cannabis to treat opioid use disorder? You touched on this briefly.
Yeah. So I think there are a couple important things to understand. One is that, while there is evidence that cannabis can be used for pain, it's not all types of pain. And pain isn't the only reason that people start using opioids. So I think that's often conflated and people see pain and they think, oh, this is the new silver bullet, like we're going to solve our opioid problem by legalizing cannabis. We do see some correlations in states. So you can find a host of studies, some of which are, better designed than others that show that when cannabis is legalized, you see a range of opioid related outcomes that decrease, whether it's, access or deaths or overdose. What's interesting to me, though, is cannabis legalization has coincided with increased public health efforts around opioids. And that's often not addressed in these studies. So, there have been a bunch in Colorado. And if you talk to the folks at the Colorado Department of Public Health and Environment, they'll say, well, at the same time that we were legalizing cannabis, we were putting in place, easier access to opioid treatments. We were putting in place education for clinicians. We were putting in place all these public health interventions around opioids that are really hard to tangibly account for in studies. So I don't think the studies are quite as clear as the media might make them seem. But I think there's an important focus on getting more research in that space to better understand. I just like to caution policymakers that no, cannabis is not going to solve your opioid crisis. And, in some cases, some studies do suggest that it may, again, prime the reward center and, in some individuals could make it harder for them to stop using opioids. So I think it's a confusing area. And again, cannabis is a heterogeneous product. Cannabis, the cannabis plant has more than 100 different cannabinoids. Might some of them be helpful for the opioid problem? Absolutely. Are all of them helpful? Probably not. Are some of them harmful? Maybe. And so I think that's where it becomes much more complicated than the media has made it seem.
Along those lines, you talked about how, being that it's a Schedule I drug federally, it's really limited the ability to properly research it. Do you see any? Have you heard anything in the wind about that being changed in the future? The schedule?
Yeah, it's been a number of years that even some of the federal agencies have been trying to push to make a change and make it easier for researchers to access the products being used in the field for research. That's the other problem is, traditionally there's only been one place at the University of Mississippi where you can access the plants to do your study with, and they are not growing the kind of plants or, giving the kind of modes of use or products that we see in the field. And so research is is being conducted with something that's not analogous to what people are actually consuming. I think researchers have been super innovative in getting around that. There's a group in Colorado, I believe it is, where they have a mobile research van, and they tell people, go in your house, consume what you would use, and then come out and we're going to do our study. We want to see the package of what you consumed, but we're not providing it. So they're skirting around some of the hurdles of research to get a better sense of what's actually being used in the field. But I know there have been a lot of efforts, and I wish that they would at least federally, reschedule it for the purposes of research. I think that really needs to happen. And there have been all sorts of barriers to doing that, but we can hope.
Absolutely. Yeah, it's so interesting that what you're just describing with the drive-bys. That's really interesting. And there was another question too about how to make it more stringent to get a medical marijuana card and the prevention of advertising of medical marijuana. I think you covered that pretty well.
Yeah, actually, I do want to comment a little bit more on that, because there's one thing I didn't say that I want to underscore in this presentation, and that's your medical system will create a blueprint for what your adult use system looks like. If you let the horse out of the barn in one way on medical, it's really hard to get it back in on adult use. And so I think it's very important that states focus on having thoughtful, well-crafted medical policy, and not just doing a sort of check the box, we have medical, we're making it happen, but thinking about how each of the medical provisions might translate into adult use is really important. I don't know the details of Pennsylvania, so I don't know what's been done in Pennsylvania, but I've seen in other states, and I think even folks from Washington and California would tell you they had very unregulated medical systems, and it became very hard to then regulate that in a thoughtful way to prevent youth access, to protect consumer safety when you were overlaying adult use onto an existing medical program. We do have some really great examples of states that are being thoughtful on the medical side. I think, I think Hawaii has some really excellent statutes and rules in place. Minnesota as well. We've seen a number of medical states that have banned advertising. I think Rhode Island a couple of years ago revised their statutes to have a virtual advertising ban. We've seen a bunch of medical states that have plain packaging. I was in Hawaii for a conference last year and went and visited their system, and at least the place that I went to, it felt like I was in a pharmacy. The products were plain packaged. The people were, dressed in sort of white coats. It was not full of advertising. There were some medical information that was validated by the state to be available, but it did not feel like an adult use marketplace. And that's not true of all medical states. Some of them, it does feel much more like an adult use, recreational marketplace. And so I think that's something states have to sort of think through. But what you do in medical really does pave the way for what the precedent is for adult use.
Right. And another thing I'm thinking about with regard to the scheduling and research is how much of the research that we do have is even around the higher potency products. Is it pretty much, some of the hemp derived products and other things? So can you talk a little bit about that, about how is there just a lot of questions still about the higher potency and the impact of that?
Yes, a lot of questions. The state of Colorado put out a fantastic report that I'll make sure I send to you guys so you can make it available, where they reviewed the science on cannabis concentrates to find out what we know. Basically, what they found is that people can have compensatory behavior. So people will consume whatever the form of cannabis is in a way to get the delivery that they want. So whether it's a concentrate or whether it's a flower, they will consume in a way to consume the amount that they want. And they did not find a lot of evidence, in part because the science doesn't exist, suggesting that cannabis concentrates were a cause of harm. They did find a fair bit of science that consuming too much THC can be linked to a variety of negative outcomes, that most of which I covered in this presentation. But we don't have the evidence to say it's a class of product that's doing that. And I think, there are a lot of concerns with the policy solutions there. If you eliminate a class of product, if you were to say concentrates are not allowed, then you're pushing that to the illicit market, which that's not great. If you put a cap on THC, I already talked about how then you're requiring a bunch of additives to come in. So I think more of a taxation approach, taxing on THC, I think is a really valuable approach here. I also think that people could look at serving size, not just for edibles. Most edibles in states, you can only have 10 milligrams of THC per serving, up to 100 per package. I think we could extend that into other products as well, so that we don't have, concentrate products that in theory are probably 1,000 servings, or at least if you do, that you're labeling it so people understand that. I think there are a lot of other approaches that could be taken than what we've seen proposed legislatively, mostly just because I worry about unintended consequences of the policies being proposed. But it's a complicated area without, like many things in cannabis, without good science to support, what we probably need to do to protect public health and safety.
Right. And speaking of tax and tax revenue, have you seen a kind of a sweet spot in states where there's a good policy to have? Because I understand in some states where the tax is too high, it can propel the illicit market. And then in other cases, when it's too low, it can almost have the same. So are there good practices there that you've seen?
Yeah, I'm not an economist, and there's some super smart economists that could weigh in better than I could. I think it's interesting, my home state of Washington, we have the highest tax of 37%. Oregon, I think, is at 17%. You can still find products that cost the same. You can still find a $3 gram in both states. So, the tax is not totally prohibiting the market from meeting what they think is the going rate for cannabis. But again, I do think that if states were redoing it, they might take a much more careful look at some of these more innovative tax approaches, taxing on THC, et cetera, because those are probably going to be associated with some behavior change that has positive effects for public health and safety in the future. Yeah.
Wonderful. Thank you. Judy or Bob, do either of you have any questions for Dr. Schauer?
I don't know, this might be like a much bigger conversation, but you talked a little bit about the tension between capitalism and the capital markets and regulation. So like, what are your thoughts about that? Like, now that we certainly see that, the marijuana, the cannabis industry is an industry, is fueled by, like the same thing as it's basically the same as the tobacco industry. How does that affect, or what's your recommendation for getting sensible regulation imposed?
Yeah, I think, I covered some of the policy variables that I think we need to do a careful job on. And I think having regulation that, again, has at its heart youth prevention, consumer safety, and equity is really important. And we just need to keep reminding ourselves of that so that, people aren't swayed by sort of monetary forces. But it's challenging given the way that we're regulating. Yeah, I wish I had better answers for you. It's a tough question.
And then I guess one more question. And so, we see like here in Pennsylvania, there's been some legislation introduced, and it's pretty much the same type of legislation. So when you talk about the regulation, are you talking about the stuff that comes after the legislation is passed?
Yeah.
Okay.
And actually, I did think of something else on your comment. I wouldn't say the cannabis industry is the tobacco industry at all at this point. The tobacco industry is consolidated into a handful of companies. What we see in the cannabis industry is a range. I think we're starting to see that consolidation happen. And I think part of the opportunity here is not to end up with, 6, 8, whatever consolidated cannabis companies that run everything. And I think that's important for equity as well, that we do need to think about how the market is structured to support small business and medium-sized business. And I think that will result in a very different marketplace than the tobacco industry. But I mean, we do know that the tobacco industry has been waiting to get into the cannabis industry. We know the same is true of the alcohol industry. And I think the more that consolidation happens and the more the market architecture that comes out of state legalization and ultimately when and if it happens, federal legalization, the more likely it is that we will see something that evolves into something that looks like the tobacco industry. Yeah. So sorry, what was your other question?
No, thank you for that clarification. And we do see that in all this legislation, like, it's going to fuel
Oh, yes, the process.
the
Yes.
little,
So,
the entrepreneur and they're,
yeah.
they're
So what I talked about today is a mix of things that might appear in statute that might be passed legislatively, but would also occur in rule. And states have really varied with that. So I'll give you a perfect example on the Eastern Corridor. If you look at New York's adult use bill, it alludes to a lot of the policy variables I talked about, but it says, the Cannabis Control Commission may implement rules to do the following or including the following. It doesn't actually put that in statute. It empowers the rulemaking body with doing that. So then you have to think about who's on your rulemaking body, what's the composition of that, that is in statute in every state. On the other hand, Connecticut, their statute is much more specific. They actually spell out in statute, this is what the advertising provisions are going to be. This is some of what the packaging and labeling is going to be. And so Connecticut, I don't even believe they've had to do rulemaking. They've issued a guidance document because their statute is much more detailed than New York's, for example. And there are pros and cons to doing it, one way or the other. A lot depends on what's the composition of the board. Are they dominant on industry side? And, the rules are going to be very focused on industry and profits and less on consumer safety. Is it a balanced board? When you put it in statute, you have to go back to the legislature to change everything. And so that has created some challenges for states that have a lot in statute. Anytime they want to do something, they've got to go back through a legislative process that can take time, whereas rulemaking is typically a bit quicker. So it's a balancing scale. Again, I think states have to figure out what works best for them.
I think in Pennsylvania, we just found out that the final rules for the medical marijuana program, which was put into place, in
2017 or 18, something like that.
I think just went into effect, like in 2021. So
okay.
they were operating under temporary regulations for a really, really long time.
Okay.
Yeah. Anyway, okay. Thank you.
Yeah.
It's just a bit of a huge maze.
Yes.
I had a question for you too, because we work a lot with clinicians who are, whether they're inpatient, outpatient, treatment providers I was just speaking with the clinical director the clinical director at Caron Treatment Center, which is in Warnersville, PA. It's 60 years old. It's 200 beds. It's a very well-respected, treatment center. They treat adolescents. And I was talking to their clinical director, and he told me that I could quote him on this, that that currently, and this is a much bigger number, 45% of their admissions of adolescents and young adults, meaning anyone under the age of 25 down to, I think, 13 or so is the youngest patient that they would have, they have identified that cannabis is their first or second substance of use, primary or secondary substance of use. And that of that population, 90% of those patients use cannabis as part of their polysubstance use. They've also seen a shift in that 10 to 15% of kids with an identified substance use or cannabis use disorder have been hospitalized for cannabis-induced psychosis. This is just their treatment center, but this is something that he will take to the bank. So there's that to go on, but also that we're hearing anecdotally from so many outpatient treatment providers who work with adolescents that they have a caregiver who has a card for that, a medical marijuana card for them, and that anxiety is what they're identifying. Anxiety is one of the 23 medical conditions that Pennsylvania identifies as being will allow you to get a medical marijuana card. And the process is pretty easy. You can do telemedicine, online. So anyway, My question for you is, do you have any aggregate information from states that have medical marijuana as far as what are the conditions that young people are identifying the need for medical marijuana?
Yeah, in terms of young people, I'm less certain about that. There's some studies that have looked at, what people report as being the primary reason for use, but it's mostly adults. Most states that I've spoken with that have medical don't have a huge proportion of youth that are accessing cannabis medically with a caregiver. It's a pretty small faction of their program. So I'm not as well versed in that. But I think the anxiety piece is really interesting. And traditionally, we see people say they're using cannabis for pain, for sleep, for anxiety, depression. What's interesting to me is the anxiety depression piece. Data from the National Academy of Sciences report suggests that cannabis can actually exacerbate that and make that worse. For anxiety, the science is mostly around social anxiety, and there's not as much around other forms of anxiety. But I think it's interesting that people may be using something that may be complicating their mental health condition, not necessarily helping it. But yeah, I can't say I'm super surprised by those treatment center numbers. And, we often see treatment is mandated to youth, and so the numbers may be higher. I think when you look at a population, you may not see the same trends, but certainly treatment providers are sort of at the forefront of better understanding the types of products that kids are using, the problems that they're causing, the reasons for use. And that's really important information for us to learn from, and should be entered into the thinking about policy here as well. And the psychosis piece, that's really important to underscore. I once heard a clinician say that there aren't a lot of factors that can be intervened on for schizophrenia, for development of schizophrenia in youth. Cannabis is one of the only factors where you really can intervene to make a big difference in terms of whether or not a youth will be diagnosed or diagnosed with a severe case, that the evidence is that strong. So I think that's important to pay attention to. And every year that we can delay youth from using cannabis is important, because the brain is that much more developed. I think it's a bit naive to take a totally abstinence-only approach, but I do think the formative work from states is suggesting help youth understand, focus on what you want in the next year or two, and cannabis is going to be a problem in that. And really think carefully about if you want to jeopardize your short-term goals.
Great. Thank you so much for that. So a question just popped in. I think, this will be our last question. We're getting close to 10:30 time. Great presentation. Here's a touchy question. The cannabis industry is an industry that profits off of addiction. 80% of their profits are from the individuals who would meet diagnostic criteria for a substance use disorder. Why are we concerned with who's profiting? Why not hand it over to big tobacco, who is on a short leash and is scrutinized by the federal government and have to follow federal advertising rules? Why are we concerned with mom and pop shops making money off of substance abuse? If we did this, they would streamline it, reduce costs, put all competition out of business, including the black market, which in states where it is currently legal, the black market is thriving.
Yeah, that's an interesting comment. Fortunately, I know a lot about the tobacco industry, because that's where I sort of started my public health career, was focused on tobacco prevention and control. There's some really big differences. We do not have, nor do I think we will ever have, a master settlement against the cannabis industry. And we have that against the tobacco industry. We have documented evidence of the harms of their product in causal ways. Tobacco affects negatively basically every part of the body in a causal way. We just don't have the science to suggest that for cannabis. Another huge difference with cannabis is I can't stand here and tell you that tobacco has any medical uses that are supported by the science. And I can stand here and legitimately tell you that the science does support certain medical uses of cannabis. So I think there's some big differences, and there are some operators that are very focused on legitimately reaching medical cannabis patients for legitimate uses. And so I think it's very hard to it's hard for me to put the whole industry sort of in this one bucket over here. Certainly there are operators that want to grow their profit, and the way that they're going to do that is by getting more people to consume and more people to consume more frequently, and there will be negative health effects from that, and that's not good. But I don't think that all cannabis businesses are like that. I also think, the reason that states spend so much time talking about equity in the industry is we have had a substance that, unlike any other, has disproportionately impacted certain communities. And Black and brown communities have borne a lot of impact from the criminalization of cannabis. And it is absolutely wrong to legalize a substance and give all the profits to white men. So I think that's the reason that the equity in the marketplace is important. And we do have to think carefully about who we want in the marketplace. And I think that's where you see states moving to have these equity programs. My point, though, is always the equity discussion needs to move beyond the market. Not everybody who's in a disproportionately affected community or has had personal experiences with the criminalization of cannabis wants to work in a cannabis store or own a cannabis store. So we need to think more broadly about where are we investing in opportunity for those individuals to get more equity. So I think it's a really complicated area, and the answers, at least for me, the answers here are not nearly as easy as the answers when we think about the tobacco industry, both because of what we know about the science and what we know about the operators. The tobacco industry, again, being, found as racketeers, it's pretty hard to overcome that. But yeah, I think it's an interesting point, and certainly one that a lot of people should keep talking about.
Wonderful. Thank you so much. And since we were just talking about youth and anxiety, we do have that program coming up where we'll talk about ways to appropriately and healthfully address anxiety rather than masking it with any substances. So we're really looking forward to that on February 8th. But I just put the link to the survey. I hope you folks will take this survey and let us know your feedback. Dr. Schauer, we can't thank you enough. This was absolutely amazing. We really appreciate your time, and especially given the early hours out there in Washington. Thank you so very much.
Yeah, thanks a lot for having me. It was a pleasure.
Thank you very much.
Thank you.